This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, and welcome to the Neurology podcast. This is Dan Ackerman from St. Luke's University Health Network in Bethlehem, Pennsylvania. And today I have the pleasure of talking with Nancy Newman. Nancy is the director of the section of neuro-ophthalmology and professor of ophthalmology and neurology. She's also an instructor in neurological surgery and all-around brainiac wrangler at Emory University. We are also joined by Valérie Biousse. Valérie is professor of ophthalmology and neurology, also at Emory University. Today's episode kicks off a special two-part series. We all know that central retinal artery occlusion can present unique challenges with regard to management and treatment, and there have been a lot of different teachings over the years. Nancy and Valérie have so much valuable information to share, we didn't want to leave anything out. Today, we're going to be talking about central and branch retinal artery occlusions, a very interesting subtype of stroke and something that we've all been trained on in a lot of different ways. And so we're hoping we can clear up some of the confusion today and talk about some of their recent publications and expertise. We're going to dive even deeper in part 2, so be sure to come back. Nancy, Valérie, thank you so much for joining us on the podcast.
Our pleasure. Our pleasure.
So I just wanted to start by making sure we're on the same page here. So first, what's the most common sort of presentation for central retinal artery occlusion, branch retinal artery occlusion? And we might addend those as CRAO and BRAO for now. But what's the most common presentation? And is this still a clinical diagnosis? Or do we need some of these other really cool, fancy tools to visualize what's going on with blood flow in the back of the eye?
A CRAO or a BRAO is a stroke to a piece of brain because the eye is a piece of brain, especially the neurosensory retina. And the blood supply to that piece of brain is a branch off the anterior circulation. So we're dealing with just another stroke in its own way, but it has some special aspects to it. It's going to present with vision loss. If it's a ophthalmic artery occlusion or a central retinal artery occlusion, it's going to be likely very bad vision loss unless there's a tiny little vessel sparing the central region of the macula. And if it's a branch retinal artery occlusion, it will be often the top or the bottom of vision being lost. And the diagnosis has to be made by looking in the eye. You can't assume whether someone is old or young. You can't assume because of vascular risk factors that it's a CRAO or a BRAO causing the vision loss. Neurologists know about those two entities, but they don't know a whole lot about the other entities that can affect the eye and give central vision loss or upper or lower vision loss. You can have a retinal detachment, a hemorrhage, an anterior ischemic optic neuropathy. You can have a sudden compression from a pituitary apoplexy. And there's so many things that can cause this vision loss that you must absolutely make the diagnosis for two reasons. One is you don't want to miss these other things. And two, as we're going to talk about later, there may be potentials for treatment, and you don't want to give the wrong treatment for an assumption of a diagnosis. And then finally, there's giant cell arteritis. If you're dealing with the correct population age of over 50 and certainly over 60, you want to make sure that you rule out giant cell arteritis, even if it is a central retinal artery occlusion. Now, usually you don't get branch retinal artery occlusions with giant cell arteritis. But if you're talking about a CRAO or an ophthalmic artery occlusion, you better be sure that gets ruled out from the beginning.
So what you're saying is I've been a little bit too confident in the past diagnosing these based on that sort of classic description of sudden painless monocular vision loss, even if it's a curtain from above or a curtain from below. There really are some important mimics we need to rule out, and we need to do that by looking in the back of the eye.
You really have to. And it's like the old days when we didn't have treatments for MS. If you got optic neuritis diagnosis wrong, who cared? There really wasn't much you could do anyway. But we've entered a different era here, and you absolutely have to know. Even if we didn't have treatments for CRAO, we do have treatments for giant cell arteritis. We do have treatments for retinal detachment before it gets worse. We do have treatments for intraocular hemorrhages. We don't have treatments for the optic neuropathies too much, but there are consequences.
In looking in the back of the eye, are we talking about classic fundoscopy, or do you need a fundus camera? Can we be doing optic nerve ultrasound? Are there other confirmatory tests? Don't get me wrong, I'm still carrying my ophthalmoscope and I use it, but there's a little variability there.
We can get into later the whole emperor's new clothes thing. Do you really look with your ophthalmoscope? And do you really see anything? Let's start with basics. You have a chance to see directly a piece of brain potentially having an infarction. That's pretty amazing. And I don't think it matters as much how you see that piece of brain as much as it matters that you do see that piece of brain in some way and that you recognize what you're seeing. And the reality is, in the old days, either you or a consultant ophthalmologist absolutely had to take a look. Nowadays, technology has caught up and there are much better ways of immediately getting a look at that piece of brain. And it's the non-mydriatic cameras, especially those that also have optical coherence tomography abilities, which look at the thickness of the retina and what's going on right in real time very early. And so we have our own bias against ultrasound of the eye. And I think Valerie's going to talk a little bit about that because the ED docs, they're hanging out there. They don't have people to help them. If you're lucky enough to have an ophthalmologist or an ophthalmology resident right there to look, that's wonderful. But they're going to want to dilate the pupil. That takes time. We like to believe that when we say time is brain, that we say time is retina. And so it even slows it down if you've got somebody right there. If you're lucky enough that the patient was seen by outside and they confirm that they see a CRAO, that's helpful to you. Although by that time, if they've really seen somebody on the outside, they're going to be outside of whatever window you think is necessary too for treatment. But I'm going to let Valerie chime in here because we both have been pushing this flag for a while now that it's hard and we don't expect non-ophthalmologists to be able to accurately look in the back of the eye, especially without pupillary dilation and especially in the ED setting. And the reality too is if you're seeing a hyperacute central retinal artery occlusion, that fundus may be normal when you look at it. And it's only the OCT that gives you your answer. What do you think, Valerie?
I'm going to give the side of the ophthalmologist here, which is, let's be realistic, no ophthalmologist will ever tell you for sure that the patient has a CRAO without pharmacologic dilation of the pupil with only a direct ophthalmoscope. They just won't do it. And they won't do it because the tool is great, but it's too difficult to use and the field of view is way too small for you to be 100% sure. And when we think about the consequences of making the wrong diagnosis in this patient, you just don't want to take a risk. Because when you're an ophthalmologist and you look at the back of the eye, not only do you want to say it's a CRAO, but you want to say, I did not see any emboli, which helps you. Or I saw emboli, which helps you even more because to look for a source of embolus. Or I saw no emboli and multiple areas of retinal ischemia, what we call cotton wool spots, which are tiny infarctions of the retina. And that really pushes giant cell arteritis way up to the top of the differential diagnosis. And you need to roll out a retinal detachment, which you cannot do with a direct ophthalmoscope, certainly cannot do without dilation of the pupil, and you need to roll out other problems. So the truth is in 2025, 2026, we need to use modern ways to look at the back of the eye, whether it be a sophisticated ophthalmologist with all the bells and whistles and the toys that we use in the eye clinic, or proper ocular imaging. So ocular imaging in the emergency department or in the neurology clinic, that's where the big problem comes in, correct? Because you don't have access to it unless you happen to have one of those fancy little camera in your pocket, which few people have. But it's changing. The ocular ultrasound is something that we have been arguing about with our colleagues from the emergency department for a long time. And you know very well that the concept of POCUS, point of care ultrasound, has dramatically expanded for routine care in the ED. And it's really wonderful because they have those multidisciplinary ultrasound machines that you can use on any part of the body. And you can do screening for a lot of bad things you don't want to miss in the ED. So people started using them for the eye. And if you have indeed a really big retinal detachment, you're going to see it. But the problem is you're going to miss everything else because the number of false negative is extraordinarily high. And the reason is not because ultrasound is not good. Ultrasound is a great technology that's used every day in the eye clinic. But what people forget is that we don't use the same machines at all. Ocular ultrasound requires extraordinarily high resolution, very sophisticated machines that are exclusively ocular ultrasound machine. What you use in the ED is extraordinarily basic. And so it can help grossly triage if you have nothing else, but it's absolutely unreliable. And so you can make a diagnosis of, for example, retinal detachment on an ultrasound, but you cannot rule out a retinal detachment. And you cannot make a positive diagnosis of CRAO because you just don't see it. So if you're lucky, you may see a calcific embolus, what we call the spot sign, at the level of the lamina cribrosa on the optic nerve head. You're never going to see that. It's 1 out of 20 CRAO has that. So if you see it, okay, but if you don't see it, you don't see it. So why bother? Just take a picture with a camera that's going to give you color photos, and if you're very sophisticated, OCT, so that you can make a positive diagnosis. Or you need to have an ophthalmologist on site who is going to do it for you, but the problem is the vast majority of EDs do not have an ophthalmologist on site. And when we have access to one, it takes forever to have the ophthalmologist come to the ED to make a diagnosis, which is not compatible with the concept of time is retina, similar to time is brain. And that's what we're talking about today. Time is retina, and therefore we need to develop strategies to accelerate the diagnosis and count every minute from the onset of vision loss to the initiation of the appropriate workup, secondary prevention, and possibly be treatment to try to recover vision.
And the advantage of having that kind of imaging too, of course, is that you can immediately send that tele-ophthalmology to someone who can interpret it for you if you are not comfortable doing that. And AI at some point, and I was going to say, and not very long from now, is going to be able to at least tell you that something's abnormal, and at the very best is actually going to exquisitely be able to tell you that you have a hyperacute CRAO by a combination of AI, of the photograph, and of the OCT.
Yeah, there are already AI algorithms that have been shown to detect a very acute CRAO within 4 hours of vision loss with about 86% accuracy. Those are not available for routine clinical use, but it's the very near future.
But to do that, you need pictures.
You need pictures.
You need imaging.
Picking up 86% of those CRAOs, that's probably better than the neurologist getting a phone call from an emergency room physician, APP resident, and getting a clinical description of what the patient said to the nurse who said that to the doc. I'm guessing that's probably not sensitive and specific enough for what we're talking about.
One clinical feature usually that's helpful is that it's usually painless. And if there's pain, then the GCA question, I think, has to be raised even more acutely. But there's only so many ways that poor eye can say it's not happy, and it mimics so many things.
And again, I want to highlight a retinal detachment will give acute painless vision loss, and there will be a relative afferent pupillary defect because the retina is detached. A CRAO will give acute painless vision loss, and there will be a relative afferent pupillary defect because the retina is dead. An acute optic neuropathy that's not inflammatory, anterior ischemic optic neuropathy, acute compression from apoplexy will give acute painless vision loss in one eye, and there will be a relative afferent pupillary defect because it's an optic neuropathy. So you need to look in the back or you will not know what you're doing.
Now, a couple of times you've mentioned this idea that time is retina, and I actually really enjoyed, you two published an article in the Journal of Neuro-Ophthalmology in 2020 titled Thrombolysis for Central Retinal Artery Occlusion in 2020, Time is Vision, which is, whether we say time is retina or time is vision, as a stroke neurologist, I get the concept. It's very, very near and dear. When I was trained, of course, the formal training I received was that thrombolytics, systemic thrombolytics were not indicated for CRAO or BRAO. Now, where I trained, there was a hospital of ophthalmology right nearby, and we got to see a lot of people with sudden painless loss of vision who thankfully had the opportunity to have an ophthalmology resident or attending directly looking in the back of their eye and formally helping us with that diagnosis. And seeing a lot of those patients, I really found a lot of variability in the practice. And of course, that was a little while ago now as well. Just to clear it up, should we be considering thrombolysis in patients with CRAO and BRAO? And why? What's the landscape here?
When I think CRAO, I think acute stroke, which is we need to move fast. We need to prevent a recurrent stroke. We need to decrease the risk of subsequent cardiovascular event. And for a long time, ophthalmologist eye care providers did not really believe that. And so they were taking their time, taking care of patients with an acute CRAO and not sending patients to neurologists and not sending patients to the emergency department, which is not what should be done. Once patients started reaching emergency departments because the knowledge evolved and ophthalmologists understood that this was a stroke and it was an emergency, then in the emergency department, the stroke neurologist started asking, why don't we give thrombolysis? This is about 30, 40 years ago when we were very seriously beginning to give thrombolysis to patients with acute cerebral infarctions. And it makes complete sense. We have an occluded artery with subsequent retinal ischemia. Why not try to reopen the artery to revascularize the retina? Because we can give any other treatment, everything that has been tried, neuroprotective agents, for example. If there is no vascularization, no blood supply, the outcome is not going to be good anyway. And that's why most of the research on the topic came really from stroke neurologists. And except that the stroke neurologists didn't have access to those patients because the patients who have vision loss rightfully go see an eye doctor. And because of the disconnect between stroke neurologists, eye care providers, and emergency departments who do not have access to an ophthalmologist on site in most situations, the field has evolved extremely slowly because each time there has been a clinical trial evaluating the use of thrombolysis in very acute CRAO, either the clinical trial has failed, has been discontinued after just maybe 10, 20 patients included, or has been so slow to include that they ended up being underpowered. And that's where we are right now. So most of what we know, it is logical and it is truly the only option we currently have. It is off-label when given because we do not have level 1 evidence to support the use of thrombolysis, whether directly into the origin of the ophthalmic artery by selective catheterization through the internal carotid artery, or intravenous. It is based on anecdotal evidence, large case series, and small clinical trials that most often have failed. But what we know is that it is safe when it is done by stroke neurologists to follow the exact same rules of what they do for thrombolysis for what I will call brain stroke. And it can be done efficiently, some visual recovery, and meta-analysis have suggested that if you want to see a benefit, you have to administer the thrombolysis within 4.5 hours of vision loss. which made everybody happy because it's the window that most stroke neurologists use, correct? And so we ended up sending the message saying, that's easy. If you have an acute CRAO, just do what you know to do. Don't ask the eye care provider what to do. Give thrombolysis the way you like it. Use the thrombolytic agent you prefer, alteplase, tenecteplase, it doesn't matter. And focus on the time window. So whether you should do IV or IA is completely debated. We don't know. I don't care how you do it, as long as it's soon, fast, like right now. And most often, the truth is, it's faster to do intravenous thrombolysis than to do intra-arterial thrombolysis. And so that's why most people agree nowadays, if we're going to do it, we need to do it within 4.5 hours of vision loss after the diagnosis has been confirmed by an ophthalmologist. Remotely by reviewing fundus photographs or an OCT is just fine. And it's administered by a stroke neurologist using either alteplase or tenecteplase, following the exact same protocol, the exact same contraindication, the exact same workup, the exact same follow-up, and the exact same dose as what you do every day as a stroke neurologist. No reason to be creative. And the truth is, there is really evidence, unfortunately not level 1 evidence, to support this treatment.
We're going to pause the conversation here and pick back up with part 2, where we will hear more about management and evaluation of central retinal artery occlusion. Thank you so much for being with us today.
Thank you for having us.
Yep, our pleasure.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.